Good afternoon. At the outset, I thank the organizers, Dr. Sam, Dr. Manjit, Dr. Raki, for giving me this opportunity. So, about the robotics, our center has installed a robotic XI system in 2022, and we were predominantly doing gynecologic surgeries, urology and gastrosurgery, and some cases of cases like robotic lobectomy. So about the history of robotic surgery, the word robot is derived from the Czech word robota, means forced labor. So the advanced technology is changing the diagnostic and therapeutic trends in modern medicine. And this is the latest development and gift to surgery is the adoption of computer-assisted robot. So the concept of robotic surgery was originated from the idea of telepresence, the NASA, to reduce battlefield casualties. Then first robotic surgery with programmable universal machine for assembly in 1980 to do the brain biopsy, then RoboDoc for hip replacement, and ESOP first system approved by FDA for endoscopic surgical procedure. This is the evolution of Da Vinci technology. Initially, the 1999, the Da Vinci has come. Then 2006, the Da Vinci S has come, and in 2009, the Da Vinci Si, and in order to overcome the problems of Si, so in 2014, the Xi system has come, which has a multi-quadrant access. So means, especially for surgeries like robotic anterior resection, if you are using an Si system, you have to undock and move to the different quadrant. But this is, you can manage with that overhead boom. And the future technologies like AI-driven, this can be installed in Xi system. This has got three parts. This is the surgical console. It has a pedal 1 for disengaging robotic motion, and pedal 2 for alternating between robotic arms and adjusting camera, and 3 for cautery. And this is the surgical cart where some are using 3 arms, and some surgery require 4 arms. The first 2 arms represents the right and left arms of the surgeons. They hold the instrument, and third arm positions the endoscope, and the fourth arms will give the counter traction or perform an additional task like counter traction or following running sutures, thus eliminating the need for patient side surgeon. And this is the optical 3-dimensional vision tower, so where it is projected here so the assistant also can see it. This is how the patient will lie down in the operation theater. This is the head end of the patient. The comparison with the laparoscopy is that a lot of advantages if you are doing robotic surgery, where the 3D vision, the 7 degree of freedom, that is called the EndoWrist technology. You can in, out, left, right, the rotation, that all the tip, they can move in 7 directions, whereas in laparoscopy only 4 degree of freedom, and the motion scaling, the tremor can avoid it in 5:1 ratio. The vision is under control of the surgeon, and the magnification is almost 10 to 15 times that of laparoscopy. But few limitations like the cost. It's a bulky equipment. Cost is almost Xi costing around 20 crores. It's a bulky, limited tactile sensation and lack of haptic feedback, lack of proximity to the patient for the surgeon, and once it is docked, the resuscitation is difficult, and the consumables are very costly. And about the docking, the problem is that once it is docked, it's difficult to perform an anesthetic maneuver. But the advent of after the Xi has come, so you can undock the system in 30 seconds. The anesthesia workstation is positioned in a way that patients monitor to be visible and rapid access to anesthetic equipment if needed. For surgical or anesthetic emergency, you should have a simulation training, and for an institutional protocol, you should make a simulation training for the emergency undocking. Mainly the current application is in urology, gynecology, GI, hepatobiliary, cardiac surgery, thoracic surgery, head and neck, neurosurgery, and orthopedics. So the preoperative evaluation, though the patient, you should identify the high-risk patients, multidisciplinary decision regarding the benefits and risk of surgery, Actually speaking, no absolute contraindication, but relative contraindications like morbid obesity, severe coronary ischemia, severe stenotic valvular lesions, significant respiratory disease, patients with raised ICP, IOP, and glaucoma. The position is very important because most of the surgeries are being done in steep Trendelenburg position. So the GAMG for arms, soft silicon pad to protect the compression joint, lubrication for eyes taped with the tegardum and further padded, shoulder support, and in high-risk patients, a trial positioning is required in high-risk patients. Intra-op consideration because of the spatial restrictions, because all these equipments, the theater will be cramped, and the positioning, and you should know the consequences of the positioning, especially the respiratory, cardiovascular, CNS changes, and the duration of surgery is very much important. This is how the theater looks like. This is a case for the robotic prostatectomy. So coming to the CVS changes due to pneumoperitoneum, due to the carbon dioxide inflation and Trendelenburg position, the cardiac index decreased by 50%, increase in systemic vascular resistance, mean arterial pressure, and increased myocardial oxygen consumption. Because of the peritoneal stretch, patient can have bradyarrhythmias, respiratory system decrease because the abdominal contents will push the diaphragm, so decrease in the FRC, vital capacity, compliance of the lung, and which cause increase in the peak airway pressure that cause ventilation perfusion mismatch and intrapulmonary shunting and hypoxia. CNS, because of the head down position, this increase in the cerebral blood flow, the venous obstruction and increase in cerebral blood flow can cause increase in ICP, and which in turns to cerebral edema. And increase in IOP is also a concern because the hypercarbia can cause choroidal vasodilatation, increased pressure cause increased CVP and decrease aqueous humor outflow through episcleral veins, and hypertension causes increased aqueous humor ultrafiltration by increased ciliary artery pressure, and which causes increase in the intraocular pressure. Hepatic system, decreased portal flow, hepatic flow, and the total hepatic flow through the hepatic microcirculation, but no change in the hepatic arterial flow. GIT, decrease in gastric pH, mesenteric blood flow, gastrointestinal microcirculation blood flow, and it causes gastroesophageal regurgitation. Renal, because of the intraabdominal pressure, decrease in the renal artery, renal vein flow, and decrease in the medullary cortical flow. Endocrine catecholamine release and activation of the renin-angiotensin system. So intraoperative consideration, there can be a cardiovascular instability and hypoxia. You should exclude the causes like tracheal tube migration. If patient is very hemodynamically unstable and or hypoxemia resistant to PEEP, operation may be abandoned or converted to open procedure. ETCO2 maintained whole throughout the procedure in a normal level to reduce further increase in cerebral blood volume and intracranial pressure. The other complications like in laparoscopic surgery, subcutaneous emphysema, barotrauma, pneumomediastinum, pneumothorax, and gas embolism. It can enter into the venous circulation or lymphatics, which in turns enter into the pulmonary circulation, can cause gas embolism. The gas embolism, as you all know, the management can cause sudden fall in ETCO2, hypotension, and cardiac arrest. What we should do is deflate the pneumoperitoneum, hyperventilate with 100% oxygen. You can give a Durant position, left lateral decubitus with the head down position, and hyperbaric oxygen therapy in resistant cases. And GA with endotracheal tube, Ryle's tube insertion is required to decompress the stomach. In most of the surgeries require 2 wide-bore peripheral cannula. Unless the patient is having multiple comorbidities, we'll put central line, especially for post cases like robotic prostatectomy. IBP in selected cases. And once system is docked, check for airway, IV lines, and monitoring leads after positioning and before docking off robot. I prefer to use pressure control ventilation than volume control, but volume control is okay, but use low tidal volume and high PEEP than high tidal volume no PEEP technique. PEEP to be applied, maintenance with oxygen, air, and SIVO. Complete immobility, relaxant strategy. When we started the program, initially we were using continuous infusion, but with we are using BIS monitoring and neuromuscular monitoring for all cases, so intermittent relaxant is enough. And inhalational, there is a controversy because with the TIVA versus inhalational, TIVA has better cancer outcome than inhalational agents because of its angiogenesis, tumor proliferation, etc. Maintenance, multimodal analgesia, fluid restriction. Definitely fluid restriction is required because it will increase the chance of increase in the cerebral edema, and especially for surgeries like a robotic prostatectomy where urethral anastomosis is being done. So it's very, if you give more fluids, it's difficult for them to do anastomosis, and the DVT stocking and forced warming blanket. Post-op consideration, dependent edema can become problematic in some surgeries, long surgeries. Laryngeal edema can cause respiratory distress. The overall incidence of reintubation is 0.7 and delayed extubation is 3.5%. But the incidence of airway edema is up to 26%, and better to do laryngoscopy and cuff leak test before extubation if you suspect all these. Cerebral edema, definitely patient will have confusion and reduce the level of consciousness. The preventive strategies: limiting the operating time, limiting the head down tilt, fluid restriction, maintain EtCO2, and high-risk patients can be electively ventilated post-op. Post-op analgesia, early ambulation, multimodal epidural and facial plane blocks, PONV prophylaxis, DVT prophylaxis. The application is in urologic procedures like robotic prostatectomy, partial nephrectomy, robotic radical cystectomy, and robotic renal transplant. The robotic prostatectomy, the blood loss is reduced, the hospital stay is reduced, less pain with robotic surgery. So this study has shown that the influence of, published in BJ, the influence of steep Trendelenburg position and the pneumoperitoneum on cardiovascular, cerebrovascular, and respiratory homeostasis, where it has shown that the hemodynamic and pulmonary variables remain within safe limit, and based on NIRS, the regional cerebral oxygenation was well preserved, and CPP remained within the limits with which the cerebral blood flow is usually considered to be maintained by cerebral autoregulation. And about the intraocular pressure, usually at the end of the steep Trendelenburg position on an average of 13 millimeter higher than pre-induction value, and mainly the surgical duration and EtCO2 were the only significant predictors of IOP increase in Trendelenburg position. Postoperative vision loss, the incidence is very less, 0.0002%. It can because it can cause the most common causes optic neuropathy, but very rare incidence of permanent vision loss has been reported. But if it is the hypotension and anemia should be corrected.